I'll start with some basic vital information about the state and the COVID response in the state. We're working with a population of about 24 million, and we've done over 35,127 tests. We've had 9,497 positive cases, which is a test positivity rate of 27.1%. Now, if we consider that we're still doing mostly targeted tests, it's not like a screening test that everybody is getting tested. So I think that can account for what we have as a quite high test positivity rate. The average length of stay in hospital, in the isolation centers, is 13 days, and we have a case fatality rate of 1.3%. That's about 1.3% of the people who test positive, who are symptomatic, die. The gender distribution is still mostly male. We have about 62% preponderance in males, and then about 38% in females. The case severity, we have about 59% of the cases are mild, 38% of them are moderate, and 2% are severe, and 1% are critical cases. The proportion with comorbidities, we have about 75% of the cases without comorbidities, and 25% of them have comorbidities. The age range is still mostly between 31 and 50, that the most affected age range. We have 6 isolation facilities, or we have quite a few isolation facilities actually. Mainland Hospital Yaba with a bed capacity of 115, Unicon Health Center, which is at the stadium, Unicon Isolation Center at the stadium in Unicon has a bed capacity of 100 people. Luth has a bed capacity of 60. Bagada has a bed capacity of 118. Landmark Isolation Center, which is run in collaboration with YPO, has a bed capacity of 81. The Agidingbi Isolation Center, which is mainly reserved for infected health workers, has a bed capacity of 47. The Lekki Isolation Center has a bed capacity of 45. And then we have 3 private hospitals that have been accredited to treat COVID. And these are First Cardiology with a bed capacity of 15, Pelion Memorial Hospital with a bed capacity of 11, and Vedic Hospital with a capacity of 20. No, back, thanks. So the index case, I mean, just a little epidemiologic history. The index case was from Ogun State and was managed in Lagos from 27th February. And by 9th March, the first contact of the index case that tested positive was seen. And then we had our first local case by 17th March. And then from week 0 to 4, we had mainly over 80% of our cases were imported cases. And then by week 5 to week 8, we started having contacts from the imported cases, and then we got to the community transmission stage. Geographical distribution of cases within Lagos, the top 3 LGAs that have COVID cases are Etiosa, Lagos Mainland, and Ikeja. Next. So this graph shows the trend in cases, starting with the index case, and then showing the effect of the lockdown. At some point there, I don't have a pointer with me, and then the effect of the active community case search that we did as well, knocking door to door in the community and in health facilities, and then the effect of the decentralized sample collection also is reflected there. And then at the point where the lockdown was eased, that effect is also seen there. And then the graph has been progressively going upwards since the ease of the lockdown. Next slide. So the summary of cases, we have 9,497 confirmed cases. 5,064 of them have recovered in community. 1,470 of them were admitted into our COVID care centers and recovered. And then we have 447 currently on admission, and we evacuated or transferred out of the country 7 cases. And then 2,381 cases are considered to be still active in community, and we lost 128 of the patients, which is 1.3% of the total that have tested positive. Next slide. So this is the distribution by local government. We can see Etiosa at 1,515 cases, Alimosho 663, Kosofe 659, Ikeja 620, Oshodi Solo 496, and the rest are lower. Etiosa local government still continues to be the highest, the LGA with the highest number of positive COVID cases. Next slide. Now, this is the testing per million of the population. From the commencement of our response till now, we have continued to try and scale up our testing in all our sites, and that also accounts for sometimes why Lagos seems to have such high numbers, because we are doing a lot more tests than the rest of the country. As of by the last week, we were doing about 1,629 tests per million of the population. Next slide. So this is the analysis of the confirmed cases. We have 42% of confirmed cases in Lagos versus 58% of the rest of the country. But out of this proportion, only 20% of deaths have been in Lagos. The remaining 80% have been outside Lagos. So if we have 42% of confirmed cases and we're only accountable or accounting for 20% of the death, it seems that our treatment seems to be making an impact on the disease. Next. Oops. So we are about to transit to community care, but even in our isolation centers, we have the isolation 1 facilities where we isolate people who don't have a positive test yet, and so we don't want to keep them to commingle with people who have a positive test, so that if it's not COVID, we don't give them COVID. Then we have the isolation 2 parts of the facility where we keep people who are positive. And then we have, we are also bringing in private providers now who are complementing the numbers that we have. And then we're transiting to home-based care where we will be handling, next slide, where we'll be handling patients that are mild to moderate. The mild to moderate cases will be treated at home, while the more severe cases will then be referred to the isolation centers so that we don't saturate them. Now, like I said, we've licensed 3 health facilities now to improve the isolation space. And we have First Cardiology, Palon, Memorial Clinic, and Vedic. And like I just said a few minutes ago also, we will soon be commencing the transition to home-based care, where we will have centers in all the 57 local governments where people who come in with complaints will be tested, and then if they're positive and they have no symptoms, they will be kept at home and visited at home. There will be teams that visit them at home, and we'll also be deploying telemedicine to keep up to date with their current condition. That way, only the severe cases and the critical cases will be transferred to the isolation centers. And we are also thinking of creating some oxygenation centers in communities and also in our general hospitals, where cases that come in will be given first aid care, stabilized. Even the more severe cases will be stabilized and then transferred to the isolation centers. Next. So I will be asking the Honorable Commissioner now to talk about the inclusion of the private laboratories. Thank you.
Thank you very much, Permanent Secretary, for that very nice overview of the state of affairs in Lagos. So if you can see from this graph, you can see the quadrangles there depicting the state of the outbreak in Lagos, and where we are right now is the last quadrangle in gray, which shows that we've diagnosed over 10,000 cases in Lagos State with our aggressive testing strategy. Now, as you can tell, that is beginning to exceed our isolation capacity in our central isolation facilities, but yet we want to increase our testing capacity even more. I think we all agree that one of the tenets of managing this outbreak is to test as many people as possible so that we can employ the principle of isolation. Right now, we're testing between 500 and 800 persons a day, and in the next few weeks, we have established a consortium of laboratories. They've all passed their validation and accreditation, so we know that they can test using the molecular biology test that we call the PCR test. They've all passed with 100%, and so we'll be adding 5 private laboratories to our testing consortium in addition to our already established public laboratories headed by the Lagos State Biobank. So as we now proceed with this expanded testing strategy, we will be testing between 1,000 and 2,000 a day when these labs come on stream, which should be any time from next week. Now, based on our track record and based on our positivity rates of about 20%, and that fluctuates, sometimes it's 20%, sometimes it's 30%, sometimes it even goes as high as 50% of the people that we sample. But that just depends on who presents themselves for testing. So if we start to get large numbers of people that are positive, and as I've spelt out before, and as you've just heard from the Permanent Secretary, we need another strategy for isolation, and that is why we have done 2 things. We've also started to accredit private hospitals who are prepared to join the COVID-19 response. So far, we've accredited 3 hospitals, and we've got about 5 more in the pipeline that want to admit COVID-19 patients and manage COVID-19 cases. At the moment, it is illegal to manage COVID-19 outside of an accredited facility, and you will see the names of the facilities. And therefore, as the public, we implore you not to go to any facility and be treated or tested if they are not facilities that have been accredited by the government. It is dangerous to do that. You might put yourself and the rest of your family members in danger, and you may certainly put staff of those facilities in danger if they are not practicing according to the standards that the government of Lagos has laid down. So, finally, to cope with the numbers of positive patients that we're seeing, we've incorporated what we call the home-based care, or the decentralization of isolation to the community, and we will be looking for homes where people can be adequately isolated in their private environment, which doesn't pose danger to other members of their families or to the community at large. Next slide, please. So the testing facilities, as we've established at the moment, are the Lagos University Teaching Hospital, or LUTH, the Lagos State Biobank, the Nigerian Institute of Medical Research, and the Central Public Health Laboratory in Yaba. We've also included some private facilities, and on the next slide you will see the names of those private facilities. Next slide. The names of the laboratories are, the private laboratories are Total Medical Services, SynLab, 54Gene, Medbury, Biologics, O2 Medical Services, and Clean Lancet Laboratories. They've all passed their validation. They have been accredited. We're just going through the logistics of them coming into the consortium. And by next week, these laboratories are going to be testing on behalf of government to provide an expanded testing strategy so that we can get a clearer understanding of what the outbreak is doing in Lagos State. Next slide. Well, that's the end of the presentation. And I'll be happy to take questions, and if those questions are more relevant to the Primary Healthcare Board or to the Health Service Commission, I will defer those questions to my colleagues. So happy to take questions now. Okay, thank you very much. So if you could go back to the local government distribution graph so that we can look through that a bit more carefully. There you go. No, back. One more? Yes. So you can see there that Etiosa, Koshofe, and Ikeja used to be the top local governments affected. What has happened, what has changed in the last 4 weeks is that Alimosho has come up very quickly. And that is now the second highest local government in Lagos State. But by and large, we're seeing an increased number of distribution across all local governments. We're seeing activity in Ekpe, in Badagry, and just like we saw with other local governments, in time, as community spread continues, the communities that are least affected at the moment will increase their incidence or their prevalence, and we will start to normalize across all the local governments. So this is just the pattern of the growing community transmission across the state. So right now, the top local governments remain Etiosa, Alimosho, Koshofe, Ikeja, Oshodi, Surulere, and Lagos mainland. Your question around non-compliance and non-pharmaceutical interventions, which are basically the social distancing principles, I think, our messaging continues to be clear. We've not relaxed our messaging on social distancing and unnecessary movement. We've not relaxed our advice on gatherings of people at social events, schools or churches. So, there's only so much the government can do. We are spreading the message as hard as we can. We are in the middle of the outbreak. We have not even peaked yet, and therefore we're still on the upstroke. We still expect to see a lot more cases in the next month or two. And so I will use this platform again to remind Lagosians that we have not yet peaked, and Lagos is still going through the active community transmission of COVID-19. I think what may be giving you a false sense of security or confidence is that we say that most people have a mild to moderate disease. While that might be so, between 3 and 5% of Lagosians that catch this infection have an extremely severe to critical form of COVID-19, and the risk of dying in that percentage is extremely high. If you look, 2%, 3%, or 4% may seem like a small percentage, but even 1% of 25 million people is a lot of Lagosians, is 250,000 Lagosians. Now, we're not prepared to lose 250,000 Lagosians, and we certainly would not like to even contemplate that number. So I appeal to Lagosians, particularly people who we believe are in the vulnerable category, anybody over the age of 50 or 55 with underlying conditions such as hypertension, diabetes, obesity, or any other medical condition that interferes with your immune system. You are extremely vulnerable to COVID-19. And the young people in our community may be going out there catching the virus with mild or asymptomatic disease, but you certainly go home in the evenings and you expose your parents or your grandparents or other people with vulnerabilities. And nobody wants to lose their parents or their grandparents. So I appeal to Lagosians, keep practicing the social distancing principles that we keep advising, and let's hope that this practice will help to continue to flatten the curve and protect certain vulnerable members of community. I think you asked, are we flattening the curve? Well, if you compare what's happening in Lagos to what's happening in Northern Hemisphere countries like Europe and America, it is certainly clear that we have less cases. You may argue that we have less cases because we're not testing enough, but we have less COVID-19 infected patients. And that is what we're particularly looking at now. If we were suddenly seeing hundreds of people dying in Lagos, then we would admit that we don't have a control over this outbreak. But we're not seeing that. It thus means that something we're doing in Lagos is working. Either Lagosians are practicing some degree of social distancing and flattening the curve through behavior, or that our numerous isolation centers are rescuing people from death, or that when people turn positive and we give them that information and advise them, if they are reluctant to come into our isolation centers, that they isolate themselves at home and bring to our attention if their condition starts to deteriorate, then certainly we are seeing a steady, constant number of people severely affected with COVID, and it is not by any means escalating beyond our capacity to manage. So in that degree, I believe we may be flattening the curve from the evidence that we're not seeing people dying in community, we're not seeing excessive mortality, our morgues are not filling up, and certainly there are not people dying on the streets, as we have seen in other communities. A question about the next lockdown. Well, that discussion has not manifested yet in the executive. We believe that we are managing a delicate balance between public health crisis and the economic livelihood of Lagosians. If things were getting out of hand, we would certainly consider another lockdown. But if you recall, Lagos has been at this long before our index case. We've had a significant level of preparedness, and as such, we believe that we have found, at this point in time, the balance between managing the public health crisis and managing economic livelihood in the state of Lagos. Your question around psychosocial support, I can break that down into three. There is psychosocial support for our doctors and healthcare professionals who are getting infected or, in fact, are being stigmatized by community. Even us as professionals in the Ministry of Health and myself as the Commissioner of Health, I get stigmatized and I need psychosocial support. But that transcends across the whole spectrum of front and backline healthcare professionals. So we are stigmatized, and when we catch the infection, that stigma even increases. And we are providing psychosocial support for the medical personnel. We're trying to address the issue of stigma. COVID is a virus no different from the common cold or influenza. And there is no reason to stigmatize somebody that catches the cold or catches the flu or catches malaria. It's not a criminal act to catch COVID-19. You haven't done anything wrong by catching COVID-19. And therefore, there is no reason for you to be stigmatized, and there is no reason for community to stigmatize you. So I am appealing to Lagosians. Somebody with COVID is just somebody that caught a cold that we call COVID-19. It is your responsibility to support that person like you would support anybody in your community that catches a cold or catches the flu or catches malaria. Please let us exhibit the cultural tenets of brotherhood and sisterly love amongst ourselves, and let us desist from the very negative attribute of stigmatization. For our patients who catch COVID-19, we give them psychosocial support over the phone, even before we admit them, and certainly on the wards, they get a lot of psychosocial support from our professional staff, and indeed, they give each other psychosocial support and encouragement when they are on the wards, in the open wards of our isolation centers. They form extremely powerful bonds amongst themselves. They exchange their experiences, and they encourage each other while they are on admission. Of course, there are members of community who are not infected but affected by COVID. And what do I mean by that? So you may be in a household where there is a positive person, and the community around you know that there is a positive person in that household. Then the other members of the family get stigmatized, and they are what we would classify as affected instead of infected. And so even close members of family who are infected with COVID may become affected by this negative attribute of stigmatization. On the issue of home-based care, I will start to answer the question, and I will defer the rest of it to the permanent secretary in the Primary Healthcare Board. Certainly in this dispensation, we have gone to extreme lengths to strengthen the primary healthcare platform. We've instituted very competent governance boards. We're about to strengthen the infrastructure. We've employed a significant number of more staff at the primary healthcare level. And now that we're decentralizing care to community, we are going to be using the much improved, much more empowered primary healthcare platform to manage home-based care. And that's why it's taken us a couple of weeks to organize it, because it requires a significant amount of logistics, planning, and implementation. But in the next 2 or 3 weeks, we will be shifting management of COVID, asymptomatic to mild cases, to the community at the grassroots level to be monitored by the primary healthcare platform. Dr. Aina.
Thank you, Honorable Commissioner, for giving me the opportunity. I think from the foregoing, what is obvious, marathon with COVID-19 infection. And since we have active community transmission, it's something we have to live with. Number one, the primary care platform had already been involved all along, ever since the outbreak of this disease. If you look at some of the slides that were shown earlier, the whole structure was involved in surveillance and active At that point, we started seeing the graph going up. We started recording more positive tests because we actually went into the community to search for cases, test them, and then bring them out. Now that we have active community case transmission, of course, we know that we can't take it all. Government cannot handle everything. And that's why you see us changing strategy, involving private sector. But of most importance is that the community at this point must take ownership of that care. And if community is able to take ownership of that care, that means the issue of stigmatization will go down. They will also be able to offer psychosocial support to members of their community. And how are we going to do this? In the next few days, you start seeing us, especially a lot of the medical officers of health and their surveillance officers, trying to track some of those that are already under home care by default. Of course, we cannot deny that some of our people are not reporting to the isolation centers, maybe because of stigmatization. Of course, some of them could have gotten well, some of them could have deteriorated and now come out much later. But the onus is that government must still try to see how we are going to find out their current state of health, either by phone and sometimes by visitations to actually, how are you doing? If you are deteriorating, we bring you out into our isolation centers. Also, part of the strategy, we are going to use the primary care centers to get involved in case management is that the National Primary Care Development Agency is giving us tremendous support in terms of training all staff. As at this moment, a lot of training is going on for all our medical officers of health and all the voluntary health workers down the line. We are also going to use that system to change the pattern of our communication ab initio. Of course, some of your observations that a lot of our people still don't think this is a reality. And I think what is responsible for that has to do with our demographic structure. You know, we have a significant young population who have good immunity, so our patients are actually mild. Majority of them are mild and asymptomatic. That may be giving people a false sense of confidence. And that's why I think you as partners in progress too, we have to let people change their behavior that COVID-19 is actually with us and is actually real in our communities. And people must just imbibe those positive health behavior of social distancing, wearing their face mask, and actually basic hygiene if we want to actually bring this thing under control in the not too distant future. So we are going to also start with this concept of community care centers, especially piloting the first 4 local governments that are having this huge burden of disease. And what is that going to be? Of course, 60% of the cases we have admitted so far in our isolation centers are what? They are mild and asymptomatic. And I think some of them can do well, okay, and they are likely to recover. And then we want to reserve our isolation centers to be able to take care of the critically ill cases such that even our mortality, which is a little bit enviable, can still go down further. So these community care centers, of course, when they are established with the support of the federal government, it is the primary health care center within that community that will manage those centers. And then, of course, we are also going to add some innovative things to it by providing supply of oxygen apparatus, so that even when you come there, number one, you don't have to walk a long distance to get to an isolation facility in Bagada or Landmark. If you are ill within a Tiosa, there should be a community care center whereby you can easily come, even if you are asymptomatic and you do not qualify for home care. I don't want us to get discouraged. We're going to be very stringent with who qualifies for home care. If you don't qualify for home care, it is the responsibility of government to provide, even if you are asymptomatic, because we don't want you to keep on transmitting the infection anyway to your household. So we want to provide community care centers with the support of the federal government, whereby you can come recuperate for a few days. We give you some of your drugs, we monitor you there, and then you go back. But in establishing these centers, that is where the primary care concept comes in. the community must also take ownership of those centers. And that is the only way that we also be able to improve the health behavior of our people, reduce stigmatization, and then hopefully in the not too distant future, we may be able to flatten the curve. Thank you.
Okay, thank you very much. I will just take the first question and I will hand over to my colleagues, the permanent secretaries, to address some of the more detailed issues around welfare and the home-based care strategy. So what are the positives and what is encouraging us in Lagos? Well, what is encouraging us is that our testing strategy is increasing exponentially, and that Lagosians who feel they are unwell with symptoms that suggest COVID-19 are increasing, but not increasing dramatically and out of control. We are also not seeing excessive numbers of deaths. So if the outbreak was getting out of control, and as I said earlier on, we were seeing lots of fatalities and mortalities beyond our capacity to manage, and that our high care facilities were full to the brim, then it would be source for concern. Right now, we're continuing to increase our isolation center capacity. We're going to be opening 2 new facilities next week, one at Yaba and one in Ikeja. And we have plans for more. So we are building robust capacity for isolation, coupled with our home-based strategy. But even as we build these isolation facilities, they are not filled to the brim. They're usually around 70% occupancy, which certainly means that we have redundancy in our isolation facilities and that we're not being overwhelmed by this outbreak in Lagos State, and that our strategies that we've deployed, of which there are numerous aspects, are certainly making an impact on holding the effect of this virus on citizens of Lagos State. So I will hand over the platform to my colleague from the Health Service Commission to talk about the welfare packages of the healthcare professionals, and also my colleague from the primary healthcare to talk about more detailed aspects of the home-based care. And so far, we've actually conducted over 15,000 PCR tests, which is more than the whole of Nigeria put together. So we are certainly carrying on with our aggressive strategy to identify where this virus is in Lagos. And as you've heard from my previous presentation, our strategy is increasing in that regard. So we'll be carrying out more than 1,000 tests per day in the following coming weeks.
Thank you, Honorable Commissioner. Good afternoon, gentlemen of the press. I want to talk about the welfare of our staff in the isolation centers. I want to say that they are all well taken care of. We give them accommodation and we feed them 3 times daily. And Mr. Governor has been generous. Despite the regular salary, he gives them incentives package on a monthly basis. Some people joined midway That's why they didn't get their something in May yet, but it will be paid along with the June allowance. So far, so good. Also, insurance package, they have good insurance package, both by Ledway and Lasaco. And they also get members of the community, has been extending hands of fellowship, all kind of items were given to them in the isolation centers. It also extends to those working in the hospital facilities also. So I must say that their welfare is well taken care of. Thank you.
Good afternoon once again, members of the press. I think I'll try and familiarize all of us with the algorithm for our community-based intervention. You could remember about 2 months ago, we had about 20 testing centers in our different local governments. So in the next few weeks, we are going to upscale that to 57 so that everybody has a fair chance within your community to walk to the nearest primary care facility with you and get tested. And at that point too, it's not just going to be a testing center, it's going to be a platform for deploying various services. Number one, you get counseled, okay, about your fears of COVID, irrespective of the outcome of your results, okay? At that time too, at that point too, you may get some pre-qualification as per whether you'll be able to qualify for home care or not. Then subsequently, we have our environmental health officers who are currently being trained that will now make a visitation to try and assess whether your home qualifies or not. Of course, if you qualify, you may self-isolate at home, and if you are positive, and asymptomatic or mild. If not, you get up the ladder and you get to an isolation center. We are expecting that 60% of our people, since we have demonstrated, will be asymptomatic, okay, and may be able to qualify. If you don't qualify for home care and you cannot self-isolate, hopefully we'll put you in a community care center if you are mild. Okay. And then also, how are you going to further manage you as a positive asymptomatic client? There are many opportunities. We have developed many apps in form of telemedicine whereby we can actually interview you on a daily basis to ask after your condition, okay? If need be to, some of those officers will visit you to ask, how are you doing? There are certain standard things they will conduct, your oxygen level, your temperature, and if by any chance you are not improving, it's been built in that algorithm of care that you should be escalated to the next level of care. The advantage of this is that hopefully we have a judicious and better utilization of our scarce resources. At the same time too, people will hopefully get better within a comfortable environment that they are used to. Also, the community too will be able to be an active partaker, okay, and also take ownership of this particular process. Also, we are also making use of a lot of voluntary health workers. These are people that are more or less been residents in the community. We have deployed a lot of them along so many programs before. Example like TB care, HIV/AIDS, even in disease surveillance. They are quite good. They have been well trained before. We give them additional training to add to the health workforce to be able to monitor this home-based care and community care once we have rolled it out. Thank you.